we now turn to a fantastic panel of experts in California health policy, and they're going to share with us their thoughts, their perspective, their ideas, and their version of a crystal ball in connection with critical health policy issues as manifest in legislative priorities this year during the California Legislative session. What I'll do is just run through and give a brief identification of everybody on the panel, and I think you'll be incredibly amazed and thrilled to have a panel of this gravitas with us this morning. And then what we'll do is just go from left to right and have them talk again about critical health policy issues in the legislative session this year, things that relate very likely to the question, the imperative of access to health care, behavioral health, workforce, what we're doing in California in connection with CalAIM, and how we are tackling these challenges that all of you work in on a daily basis. So again, I'm delighted to let you know that we have on the stage Ted Lampert, who is the president of Children Now. We have Jed Hempton, who is here from CAP. He is the Director of Legislative Affairs. We have Assembly Member Marie Waldron. She is the Vice Chair of Assembly Health. We have Assemblyman Jim Wood, who is the Chair of Assembly Health. Last but not least, we have Anthony Wright, who is the Executive Director of California Health Access. So again, a fantastic panel of experts in health policy joining us to talk a little bit about their views. Everyone will do an introduction, talk about their views, and then we'll open things up for questions. So with that, again, please join me in giving them a warm welcome. And I will pass the baton to Assemblyman Jim Wood. Thank you.
Good morning, and thanks for the opportunity to be here. I was looking through the website that talks about this group, and I love this. The State Reform Health Policy Conference is focused on bridging the gap between healthcare policy and political reality. Too often, those with good ideas for reforming healthcare don't have a solid understanding of how the legislative process works, and I would agree with that. And those that understand politics don't always comprehend the intricacies of the healthcare system. I would agree with that, but I would also say that some of them also have an ulterior motive, and that is the other challenge that we face. So I woke up in a little bit of a feisty mood this morning, and I'll get to that, and the reason for that in a minute. But just in general, thank you. I don't have a podium here, so I'm just going to whip through. You guys all probably know a lot of statistics. I could read statistics to you. I'd rather not. But I'll read a couple just because I think they're important. 52% of Californians skipped some sort of health care last year because of cost. And that was up from 49% the year before. Clearly going in the wrong direction. Of those, 50% reported the condition is now worse. That's up, not surprisingly, from last year as well. 36% of people report having some medical debt, and 19% of those is over $5,000. The cost of healthcare is too expensive. I've been working on healthcare issues since I was elected. I'm a healthcare provider by training. I have probably managed to anger and frustrate every segment of the healthcare population of providers and system in my time as the chair, in my eighth year as chair now. But I've always been trying to do three things. One, improve access, improve quality, and make healthcare affordable. And that is the challenge. And I think that's really what brings a lot of us together here. So we've tried a variety of different ways of going about this. And people would often accuse me of kind of picking around the edges. And you know, at the end of the day, they're kind of right. It's really, really hard to tackle a monster issue. There are so many people that line up against you to fight you on that. But I'm probably the most proud of anything we've done is the creation of the Office of Healthcare Affordability. That was a Herculean effort. It took a long time to get it done. And we had huge resistance. Everybody wants to point the finger at the other guy as being the part of the problem and not take responsibility for their role in why healthcare is the way it is. And so as today, I didn't realize that, but Anthony told me last night when we had dinner, today is the second meeting of the board of the healthcare of OCA. So that it's moving and it's significant. And along the way, you know, the creation of the all-payer claims database, critically important to feeding data for this system. But the idea is to get our arms around the increasing cost of healthcare. So much of the efforts we see these days are about how we get more dollars into the system. And as long as we continue to chase that, we're never going to catch up. We're never going to get there. We have to find a way to get our arms around the cost. We can't continue to see inflation in healthcare at twice the rate of inflation in the general economy. It's simply not sustainable. And I think that, and I'll close it with this piece of it, which I think is important. All these notes here are of no value right now. But there are a couple of things we're working on this year. Two things in particular. One is around consolidation in healthcare, and I think that is a critical piece of this. There's a lot of studies now that show that consolidation does not lead to lower prices; it leads to higher prices, and we've got to get our arms around that. And the other is health information exchange. Absolutely critical component. You know, you can't get your arms around things and provide the best quality care if the entire system doesn't have access to all the necessary information. So I don't know who all's in the audience here, and it's always dangerous for me to say some of the things I do, but you know, like I said, I kind of woke up in a feisty mood this morning. But I will look and say this, in all honesty, the Office of Healthcare Affordability had major opposition to it from doctors, from medical groups, from hospitals. HIE has major opposition from doctors, medical groups, and hospitals. Consolidation has major opposition from doctors, medical groups, and hospitals. I find that really troubling. I really do. And it's not every doctor, and it's not every hospital, and it's not everyone. But there is a consistent message there, and that message is that people are desperately working to control and preserve their model. And that's the other one is HIE, and there's some big players in opposition to HIE. Every entity should be signed up for HIE now, every single one. But they're not. They're absolutely not. And I find that really, really frustrating. If our goal is to provide the highest quality care for people and get them, get as much cooperation amongst providers so they have all the right information, why is this so difficult? Because I firmly believe that some entities are trying to protect their particular model, and that's not in the best interest of patients. So I look forward to the rest of the discussion. Like I said, I think I woke up a little feisty this morning, but I woke up feisty, and I'm going to tell you this. This is kind of an interesting example of that. In today's Healthline, California Healthline, there's a story about a guy who comes from Switzerland to go to his daughter's wedding, gets appendicitis, goes to a hospital, Pennsylvania, so it's not California. He's there 14 hours. He leaves with a $42,000 bill. $42,000. That's $8,000 for 3 hours in a recovery room. Experts looked at that and said, you know what, that should have been a $12,000 to $14,000 bill, not $42,000. And the hospital charged what they could. They got away with it. He had insurance from Switzerland, but that only was going to cover $8,000. Now, I think if he'd said, you got a $14,000 bill and the Swiss government's going to pay $8,000, I think he probably would have been okay with that. But $42,000? If he had been in this country and he'd been on Medicare or he had some private insurance, the bill would have been a fraction of that. But because he didn't have that, that's what the system bears. And that's wrong. I think it's wrong. And, you know, I apologize if anybody's upset about that, but I don't think it's fair. $42,000, that just seems egregious. And when you consider other things that could have helped defray the cost. And oh yeah, he was in America, he worked enough in America that he tried to get Medicare, but he hasn't been able to get Medicare because of our system wouldn't allow it. He's struggled with that too. What's wrong with the system? 14 hours, $42,000. We have a challenge. So anyway, apologize for anybody I offended, but it's early. There'll be more people later today, I'm sure.
Well, I think it's fantastic, and I don't know about you, but I'm pretty sure everybody in the audience is glad you woke up in a feisty mood, and hope that you continue to wake up in feisty moods. I will pass the baton along to Assemblymember Waldron. Thank you.
Well, thank you so much. I'm excited to be here. I try to attend as many state of reform conferences as I can because I love the exchange of information and just the climate of being around a lot of folks who are doing good things in the healthcare industry. As was mentioned, I'm vice chair of Assembly Health. I serve alongside Dr. Wood. We also serve together in the Stanford Initiative, which deals with addiction in the brain, bringing together policymakers and researchers, which I think is a really important thing when we consider the mental health challenges we're facing, as well as the substance use challenges we're facing. Bringing that type of information exchange together is really important. A little bit about me, I've worked for over 20 years in the mental health substance use space in San Diego. I was part of the San Diego Opioid Task Force, which back then was just kind of recognizing a lot of what was going on with the opioid abuse and then heroin that was affecting many of our young people. I have transitioned that into my role here in the Assembly and is now in my 11th year in the legislature with a passion for helping people dealing with substance use, mental health, as well as some chronic conditions and AIDS, HIV, as well as those in carceral settings, which we see there's a big co-occurring, I will use that word, between people who are incarcerated and dealing with mental health and substance use that we're not tackling. People who are dealing with those issues should not be in carceral settings, they need to be in treatment. So when I sit in health committee, I put on the hat that I live every day as a mom. And I try to figure out, with all of the just bureaucratic red tape dealing with our healthcare that makes it so costly, how could I as a mom say I don't speak English? I'm trying to advocate for my child in a Medi-Cal system. How can I get them to a doctor? When I have a great health insurance plan, but yet when I need it the most, I can't get into a doctor and I go to the emergency room. I mean, at some point, it comes down to that base level. And how do we get the patient the type of care that we need? And we talk, you know, kind of high level all the time. All of these acronyms and all of these things we're trying to do and initiatives, which are great. But at the end of the day, we need efficiencies. We need a lot more technology in healthcare, which when you deal with even the state of California that has always prided itself on being ahead of things, our technology is very bad. We lack technology in so many levels. We're dealing with the same issues we dealt with 11 years ago when I started in the legislature, dealing with access. How can we get the best treatments to patients? I'm excited about what CalAIM can offer with the whole patient care and the quality outcomes, looking at value-based, you know, what will work for the patient, but we also need to make sure that we actually start out correctly and keep accountability in that system, because it can just turn into another big bureaucratic disaster that we've seen so many other government programs become. going back to some of the work I've done just in value-based care, trying to get efficiencies in healthcare. Several years ago, I worked with the California Health Benefits Review program. Actually met with the analysts, and they look at all of our bills that come through the health committee for analysis of costing. And they were restricted to a single year, 12 months. And that's because our budget is a 12-month budget. But yet, it was eye-opening when a drug like, for example, Sovaldi hit the market. And then we finally saw what could be a cure for hepatitis C. But the cost up front was very high. And then, in the long run, if we go out further than the 12 months, we could actually realize savings, and not even to mention the quality of life for the patient. All of those factors we need to weigh in when we're looking at healthcare. So when I met with the Suburb analysis, I wanted to do a 5-year outlook of, what are these costs going to be to the state budget? And in appropriations, where everything, good ideas die, they narrowed it down to 2 years. So now at least the California Health Benefits Review Program can look out to 2 years if there's a benefit, because a drug like Sovaldi and the others now that have hit the market, they may cost a high price up front, but in the next year you're saving $200,000 on a liver transplant or whatever, other issue. Not to mention the loss of work for the patient, the hospitalizations, and all of those things we deal with. The cost of healthcare, prevention is something we need to strengthen. Just the inadequate care coordination when a patient's going from one type of doctor to another. And the data exchange, of course, very important. All of those things go into the cost of healthcare. But our mental health system, our workforce problems, all of these things are priorities for us on Health Committee. We could talk forever about it. So I really just wanted to emphasize, I think getting the best care to the patient up front in the long run will save money. We need the technology to be efficient so we can follow that patient through the system and really get the best value-based care. So I'll leave it for later.
Thank you so much. Thank you so much for those comments, and thank you for bringing up CalAIM and the Justice Initiative in connection with CalAIM that really does seek to promote treatment in the carceral setting ahead of release into the community. Hopefully that's going to be one of those CalAIM initiatives that both promotes efficiencies, which is so critical, but then promotes effective transitions. So thank you for your comments about that. Thank you very much. I'll pass it along then to Jed. Thank you.
Thank you very much. Good morning, everybody. It's very happy to be here. My name is Jed Hampton. I'm the Director of Legislative Affairs for the California Association of Health Plans, and we represent 43 Knox-Keene licensed health plans across California, covering nearly 28 million Californians. So I have the fortune today of stepping in for my colleague, Nick Luizos, who is unable to be here today due to some last-minute unforeseen circumstances. So I feel very honored to be the least distinguished person on this wonderful panel and have the ability to be here today. So, as everyone here I'm sure knows, the healthcare delivery system in California especially is really going through a transformational change, and this is really across all business lines, all product lines. So the commercial market and the employer market, the small individual business market, and then obviously the major transitions happening in our Medi-Cal delivery system are really pronounced and really significant. In the lens of these transformational changes, our member plans are laser focused on continued delivery of high quality care and services, while also implementing many of these new benefits and new programs. With that being said, there's a lot to discuss in terms of what we're focused on in the year ahead. It's a pretty transformational year, and it's really coming off the heels of much of the work that has been done in the years prior in terms of getting CalAIM off the ground. So there's a lot of stuff that we're really focused on, for the upcoming year. I would say one of our largest focuses of the year is really around the effort to renew the managed care organization tax, working with the legislature and the administration to kind of bring that across the finish line, ensuring that that tax and the monies raised from that tax really go to and benefit the Medi-Cal system. That it's a fair and equitable tax, and that again it really lifts up our Medi-Cal system. So we're really pleased to see the proposal from the Newsom administration thus far. We know there's a lot of work to be done on that proposal before it makes it across the finish line. So again, we're working with the administration and the legislature to really prioritize that and focus on that this year. Speaking of Medi-Cal, and I'm sure this is going to be a topic of much discussion today, but Medi-Cal redeterminations and that process is underway. We certainly believe that that's going to have some pretty seismic shifts here in California, and we're getting closer to the cutoff date by the day. I think we're about 3 months out or so, and so from the health plan perspective, we're really focused on building up our infrastructure, building up our teams to ensure that we have capacity to ensure that those individuals who remain on Medi-Cal still have access to the same high quality services that are coordinated by our health plans. But then also those who will be transitioned off of Medi-Cal, right, and go and likely need to purchase insurance through Covered California on the individual market. We want to make sure that is really robust and up to date, and that really goes kind of it leads nicely into our third topic, around ensuring continued affordability within the healthcare delivery system. We certainly applaud Dr. Wood's leadership. He's been a true leader, in the legislature on ensuring affordability, and right now, there's no better time to make that focus even more pronounced on affordability. Obviously, there are some challenging economic times going on right now, within the state. I think within people's own family budgets. Inflation, cost of living increases, layoffs in the tech sector. I mean, a lot of these components are really driving a higher cost of living, irrespective of things happening in the healthcare delivery system. So that that would be rising drug prices, increases in utilization, inflation within the healthcare delivery system separately. So there's a lot of factors going into that, and so we are continuing our efforts to focus on affordability. Because affordability is crucial to access. I know we'll talk about that later, but affordability is really key for us. So those are some of the major things that the health plans are really focused on throughout the rest of this year.
Thank you. Thank you very much. Thematically, certainly, as we talked about all morning long, promoting efficiency, promoting better coordination, and promoting affordability certainly uppermost in the list of critical issues. Thank you for that. Thank you very much. Anthony, looking forward to hearing from you.
So good morning. My name is Anthony Wright. I'm the Executive Director of Health Access California, which is the statewide healthcare consumer advocacy coalition working for the goal of quality, affordable, equitable healthcare for all Californians. Some of my time is spent encouraging Assemblymember Wood's feistiness, especially on the issue of cost. We were very proud of the work to conceive and get past the Office of Healthcare Affordability to finally look at the issue of cost containment from a comprehensive lens. We've been, for so long, working with our friends in the legislature, working on specific issues of specific market failures, but we wanted to make sure that actually translates to a global look at how much we are spending on healthcare, setting a goal for the whole healthcare system, because we'll never meet a goal we never set. and to provide flexibility to meet that goal, but accountability if the industry doesn't. And that was an important goal. But we're also focused on some very practical patient protection efforts as well, also following up on the good work of Dr. Wood. And frankly, it was a bipartisan effort on surprise medical bills. We were able to address that issue several years ago, but we left one area blank, and even the federal government, when it approached it, left that blank, and that's the issue of ambulance surprise medical bills. People actually still are even afraid to call 911 for fear of the bill, and we want to address that in this legislative session. Other patient protections on things like making sure that people can navigate their healthcare system, and they can't do that if they don't have an accurate provider directory. So that's something that we've been working on as well. But I do actually have common cause with our friends at the health plans and others with regard to affordability. And we have a practical way right now in this year's budget in the next couple of weeks to better improve affordability in covered California. We have the money that has been raised from the individual mandate penalty, and we think that money should continue to go to making coverage more affordable, reducing cost sharing. And in fact, with that money, we could actually not just lower cost sharing, but eliminate deductibles in the Silver Plan, which is a major barrier to care for people trying to get access to care. So that's something that we hope that we can get done, not just in the next year, but in the next couple of weeks, in the conversations around the budget going forward. But I'd be remiss with an organization called Health Access if I didn't end with the effort of the vision that we're trying to get to, that we take seriously and appreciate the leadership of the governor in talking about a California for all. And in this next year, we are hopeful that we are going to take major steps to that. We have in the budget planned an expansion of Medi-Cal to fully remove the exclusion based on immigration status, which would allow 700,000 more people to be covered and have that access to health and financial security. That's a big deal. We think we can take another step this year with regard to opening up covered California, getting that federal waiver to remove the exclusion that, in covered California and take another step during that path. And I think that goes to this vision that once we get to a world where everybody in California is eligible for something, then I think we are that much closer to the universality and to having a system where the burden on figuring out your coverage should be on the system rather than the individual. We're not quite at universal coverage or universal access, but we can see it, and we need to continue that work and not lose our eyes on the prize. And I think January 2024 is going to be a big deal because we have the Medicaid expansion being documented. We have the new Medi-Cal contracts, which we're very excited about, putting new quality metrics in place for those 15 million folks in Medi-Cal. We have the plan changes, shift of a couple of million people into different plans as part of that. And then we have all of that at the same time that we're also doing the redetermination. So we have an opportunity, we have a problem that we could be taking a step back, but we can use that as an opportunity to step forward to truly the vision of a universal and equitable healthcare system, and that's what I'm excited about this year. Thank you.
Thank you, Anthony, and thank you again for your singularly powerful advocate voice. Thank you. And continuing the theme of advocacy, I'm so pleased to welcome you, Ted, and Children Now. And I think it's particularly impactful that we have you closing out this set of comments after not only the discussion about the system overall and affordability and efficiency, but frankly also after that wonderful keynote that we had from Melissa, to think about, again, from the backdrop of system issues, system efficiencies, affordability, and the impact on children from all of these competing priorities. So welcome, and thank you for closing the comments as we do this introductory panel.
Oh, well, thank you. It's an honor to be here this morning. I guess I'm not batting cleanup. I'm fifth in the lineup, but it's an honor to be here. My name is Ted Lempert. I'm president of Children Now, which is a whole child advocacy organization that is essentially trying to say, let's make kids the priority, not a slogan, but the reality. And we work on a whole range of health issues with all the folks on the panel here, from Medi-Cal accountability, thank you, Member Wood, to vision, oral health, hearing aids, certainly mental health crisis, and environmental health, and a range of issues for kids. But I want to just sort of close with our opening part with sort of sounding the alarm bell about the status of our kids in this state. I am so proud to be a Californian. I've lived here all my life. And we lead on a lot of things in this country. And we're proud, as Californians say, we lead. But we don't when it comes to kids' well-being. The Casey Foundation does a thorough study of all the states. We rank 35th in the country in terms of kids' well-being. Now, thanks to Melissa and the governor and folks here, we're actually making progress. A number of years ago, we were 42nd. But that's really intolerable. And so what we're really driving at in all the conversations here today is to actually put kids at the front of the line in all of our healthcare decisions. And I think the elephant in the room when we always talk about healthcare is it's really more of an adult-focused system. And if we really started with kids, we could get every kid the supports and preventive services they need. And when I say healthcare not being prioritized for kids, I think we see evidence of all the time, including you work with kids in healthcare, you get paid less, right? And there's a whole lot of other examples, and kids are more than half of Medi-Cal, 17% of the expenditures. I want to make a general point about the seriousness of these issues, and then just one specific issue, and I know we'll get into a lot more, because sometimes people say, oh, Ted, that's so nice you're working for kids, like pat, pat, pat. I can't think of anything more serious than the well-being of our kids. So I'm gonna give you one stat, and this gets to how our health issues are interrelated with our education issues and kids' well-being. Remember the Great Recession and the downturn 2008, 2012? No one still remembers that. We're a little afraid of something like that happening again shortly. Remember all the economic losses that we all suffered from our retirement accounts, home foreclosures, the impact on businesses. Think of all that money that was lost. Okay, so then McKinsey did a study that looked at those 4 years and the number of kids in this country that didn't graduate from high school. That was a greater economic loss to this country than all the economic losses from the Great Recession. That's how serious this work is. And so those 20% of kids that don't graduate from high school in this state is threatening our economy, is threatening our future. And part of the reasons kids don't graduate is because of the lack of preventative health care. And we do a great job in this country. If you're really sick, even though it's way too expensive, on getting that health care, we don't do a great job preventative. And we have over 5.5 million kids in Medi-Cal, only half receive that basic preventative early screening. So I'm very passionate about this, and really the overall message is kids, kids, kids. Let's start with kids and really make sure we move that 35th up to first. And I just want to mention one specific, if not right, I mean, we could all list a whole bunch of bills. One of my favorites that we're co-sponsoring this year is Senate Bill 238 by Senator Wiener, and just building off Director Stafford Jones' great leadership and how we really need to address this mental health crisis. This bill in particular deals with when a mental health treatment is denied, it's appealed immediately to the independent medical review process, the IMR. And I just want to speak personally about why this is so important. Between my wife and I, we have 5 degrees. We have all the privileges in the world raising our 3 kids, but we have spent hundreds of hours, arguing mental health claims. And my wife has actually been brought to tears so many times because it sort of re-traumatizes, right? And so if a kid breaks their arm, they're not going to get a mental health appeal denied, right? But these mental health appeals, we need to make sure that we are supporting our kids and our families and making sure that we're not denying these claims for what is so needed service. So that's just one of many bills that we're co-sponsoring that sort of gets to the heart of how we really need to move the ball and make sure, kids are prioritized in all our health policy decisions. So look forward to the questions and discussion.
Well, thank you so much. I think one question that comes to mind and a comment, frankly, following on Ted's comments, Medicaid, Medi-Cal began its life many, many years ago with a focus on mothers and children. And here we are 50 years later here in California, talking about the ongoing challenge to really ensure that critical access to children. Anthony mentioned a couple of things that are imminent in the Medi-Cal space, the new contract that's going to take effect for the managed care plans January of 2024, with a very significant focus on quality and outcomes, and the ongoing challenge to really promote those early screenings that are so critical for preventative care and getting children on the right path. And I'm so grateful that Assemblymember Waldron mentioned CalAIM, and so many of the CalAIM initiatives are aimed at promoting efficiency in the system and redressing the pernicious effects of bias that we've seen for all too long. I'm interested in hearing from everyone, and Ted, if it's okay with you, I'd love to hear your observations about what would it look like in a future state if the impacts from CalAIM's goals, as well as the new contract, as well as a refocus on children, not just in connection, of course, with the fantastic work of the Children and Youth Behavioral Health Initiative, but with the focus in the new Medi-Cal contract. What might a future state look like as a result of the new contract, the new focus on quality, the focus in CalAIM to really redress bias in the system? Very eager for your observations, all of your observations, on what good or optimal outcomes would look like.
Yeah, just real brief. I mean, an audit was done, thanks to Assemblymember Wood, and where the Medi-Cal system wasn't really serving the kids, and that's why this process is so critical. I would actually make a sort of simplistic answer that we would be doing what the federal law says. And when I say that, it's not that other states aren't necessarily following it either, but the federal law is pretty clear that every kid should get these preventative screenings, the care should be provided where the kid is at, the transportation should be provided. So that's sort of it's funny to say that's a dream, because that's what the standard is, but we are so far from meeting that standard. And we rank the bottom 7 states in terms of just getting that basic preventative screening. So through all these reform efforts, which we're very excited about, it's like, let's look at what that federal guideline is, and let's really meet it for every single one of our kids.
Thank you. Anthony?
Yeah, a couple of things. One is, we are very supportive of CalAIM as an approach to get, especially those parts that are providing more in lieu of supports, community supports, efforts that can provide better outcomes and more upstream care, especially for those most vulnerable populations, including the unhoused and others. The plans have a challenge with regard to engaging a whole new set of community groups and to do that, but we think that's those are good conversations to have, and better integrate and see if we can really mix this insurance model with a public health model, and it's not necessarily the easiest fit. And so we recognize there's a challenge there, but we think it's an important but it's important to do. I would make the case that as important as CalAIM is, it is more focused on specific populations that desperately need it. I think even the bigger change is the reprocurement and the new contracts that the Medicare managed care plans have to abide by with regard to new standards on quality and equity and access. We as a state provide tens of billions of dollars to the Medicare managed care plans under the agreement that they are providing a range of services, adequate networks, etc. And unfortunately, when we do those audits, whether it's on something as basic as childhood immunizations and vaccinations, we're not there as we're not getting what we are paying for by contract. And so we need to have more accountability there. I think it was good to have a range of new contracts. I think that one of we hope that the fact that the new plan arrangements by county that had to be determined by settlement at the end of the year is not a signal that the plans can sue their way out of accountability, but in fact we're starting from a new baseline now, and that the state has said that they're recommitted to doing that reprocurement on now a regular basis as opposed to the decades that it's been since the last one, and hopefully that could be a mechanism where this is the moment to improve, or in the next round, you will have less business. And we think that that's an important set of signals to the industry that we need to make. That at the end of the day, we don't need more plans, we need more accountability, and that's something that we're focused on in addition to the very real work of even figuring out what those metrics are and everything, but we need to have measurable, meaningful improvements in the lives of the third of the state that depends on Medicare.
Thank you.
Yeah, I mean, I think, relative to CalAIM, I mean, obviously our managed care plan partners have partnered with the Department of Healthcare Service, the administration, and, across the board, as well as some of the community groups that Anthony had mentioned, to really launch this, really innovative and really transformative program. For those who have kind of been involved in getting CalAIM up off the ground, or at least even somewhat tangentially being aware of it, it's a very, very big lift. Lots of new programs, lots of new services, lots of transformational changes, and lots of money to get it off the ground, quite frankly. So, we are heavily invested in making this initiative work. Really to improve care coordination across the board, increase health equity, and quality of life and health outcomes for the disadvantaged population that we're serving. I mean, that's crucial. That's the mission of our Medicare managed care plans, and we think that there are a variety of ways to achieve that through some of the initiatives that we're undertaking under this larger umbrella initiative. I know, just relative to some specifics around CalAIM, the population health management to prioritize wellness and services has been a big focus. It's a pretty significant program in and of itself to ensure that we deliver the best quality outcomes to individuals through a new select group of services. We're heavily invested in that. Obviously, behavioral health is a major topic. Not just in Medi-Cal, but across all healthcare delivery systems. But CalAIM really provides an exciting opportunity to do some new innovative things like medically tailored meals, street medicine programs. There's a lot of really exciting programs that the plans are really investing in. Again, with that comes the challenges, specifically if, really new provider populations, giving those populations kind of up to speed, training. I mean, managed care, this is probably the most obvious statement I'll make all morning, but managed care is complicated. And so, I think that, if you're not used to kind of working within that framework and within those parameters, it does take a little bit of time. So, we are really, totally and completely invested in this program and its success. We do think that it's going to take a little bit of time and a little bit of patience to really kind of get it running on all cylinders, considering the size and the scope of this initiative. But we're really excited about what it can bring to our beneficiaries moving forward.
Thank you so much, Assemblymember Waldron. I'm so happy that you brought up the justice involved waiver. I'm particularly interested in the promise of delivering services to both juveniles and adults in carceral settings. Look forward to hearing your observations and then having a closing set of observations from Assemblymember Woods on the promise of what you think might be the best prospects for future outcomes. Thank you.
Okay, just touching on the correctional system. When you look at the disparities in healthcare, we can't leave out the people that are incarcerated. And what created this cycle of incarceration that we see. And then looking at the systemic barriers that actually have been generational. The work we try to do is to stop this cycle so that we can help families, help people who are incarcerated, who also have children, so that those children do not continue into the cycle. One of the things we found is having continuity of care from when you're incarcerated to when you go home is really important, because within the first 2 weeks of being released from prison, even if you've been in prison for 20 years, we've seen an 8 to 10 times overdose death rate in those first 2 weeks when people come out of prison, if they are not in a continuous care system. So I did have a bill in the last session that would kind of break all the rules as far as the federal government was concerned and allow people who are still incarcerated to access the state Medicaid system 90 days prior to their release. And that was rolled into our budget and included in the CalAIM, but it still didn't get the federal approvals until this February when CMS approved it, making California the first state in the nation to be able to do that. And I think the more we can do those streamlined transitions and help people who have faced systemic barriers all their life, whether it be substance use or mental health or even just a general health care, it's really important because it's one less thing that people have to deal with when they come out. I mean, we're looking at what does our future look like if we can incorporate all the things we want to do with CalAIM. I mean, we need to start with the roadblocks. We can have all the healthcare, we can have 100% of people enrolled in healthcare, but without the providers, without the physicians, without the nurses, without the mental health treatment providers and the drug abuse counselors, we're still going to be facing the problems that we face. So looking at health disparities really quickly, a patient A from an affluent community with the best health care and patient B in an underserved area who may or may not have health care or is maybe on the state Medicaid system, both patient A and patient B should be able to and would benefit from access to preventative care early on. And that will be a big step in us being able to, you know, what Ted was saying as well with the preventative side of things, very important to help us reduce costs and bring forth access. And we need to also emphasize chronic conditions. Chronic care is a big part of our budget. Preventative would help in the long run there as well, and especially in carceral settings where we see a very high rate of people there who have chronic conditions. So.
Thank you. And in closing, we very much welcome comments from you, Assemblymember Wood, feisty or otherwise. Grateful again to hear all the comments this morning. Thank you.
Well, once again, thank you for the opportunity. Just a public service announcement here. Tomorrow, we're having a hearing, Health Committee, Public Safety Committee, and the Select Committee on fentanyl. I can't remember the rest of it. It's got a lot of words in it. A mega hearing hasn't been done in a long time that I'm aware of, as we try to begin to tackle some of the issues around fentanyl as a larger group. So that'll be tomorrow morning at 9 o'clock. I'm sitting here thinking and listening, and first of all, I very much appreciate the comments of everyone. CalAIM, I think, has tremendous promise for us, and I think a couple of things that I think are important in that. I want to give a big credit to Scott Bain, our analyst who is now retired, but he came to me when CalAIM was first being discussed. It wasn't even called CalAIM, I don't remember what it was, but it was really harder to understand the words of that one. But he came and said, you know, there's a major proposal here. We ought to have some hearings on that. And we did. And we had hearings, and it gave an opportunity for a lot of stakeholders to come out publicly and talk about some of the things that were really important to them. And some of those things, I think, really did help in the discussions and what CalAIM actually looks like. And now everybody knows that there is a CalAIM, and I think so that opportunity to have these hearings and discussions, engage with stakeholders, I think is important in what you see now. Now it's going to continue to evolve, obviously, and as it should. It's a major transformative movement in the medical system. One of the things I really hope for is that as we move forward, you know, there are populations that don't get talked about a lot. Our aging senior population, we haven't mentioned that at all, and huge needs there. CalAIM will help with that, but I think that's really, really important. In some cultures, seniors are revered in different ways than in a lot of our cultures here in this country. And we need to not forget about those people who have taken care of us all of our lives. It's time for us to take care of them at some point. I say that as a son who's taking care of an aging parent. I have my fiance who's taking care of her aging parents and the challenges we have with that and accessing healthcare. The final thing I want to leave you with is that I represent a really large rural district. It's larger than 6 states. What that looks like in the delivery of healthcare and how people access care and what their health outcomes are very different sometimes in large urban areas. And so as we move forward, what I'm always looking for is flexibility. You know, the one-size-fits-all approaches that we conjure up here in the state don't always work well for the people that the communities I represent. And so sometimes giving them the resources and recognizing that they might have just a little bit different way of doing things and letting them run with that, you're going to get great outcomes. There's so many examples of that there. But oftentimes in these small communities, especially I'll use the area on aging groups that I've met with, they don't even apply for resources because the reporting requirements and everything that go along with that don't justify the time. They're the persons who are actually applying for these programs, they're administering the programs, they're actually doing the work, and it's really, really difficult. So my plea is always, you know, think about rural communities, think about how difficult it is for them, because if we don't, the disparity gets worse over time. And so we can do a lot with a little. Just give us a little and take away some of the strings and see amazing things happen. So thank you for the opportunity.
Thank you all so much. This has been the most generous panel, thoughtful, insightful, and really folks with their fingers on the pulse of all things related to health policy in our state. So please join me in more.